Hey folks, we're going to get started soon, but apologies because of the water situation. We don't have coffee, but we do have bottled water here if you'd like to come and help yourself to bottled water. Thank you. He's going to go a little over. That video is 17 minutes. He's going to go 17 to 18 minutes. Mm-hmm.
If everybody could find their seat. I usually start the meeting with everybody get their last cup of coffee, but we don't have coffee today, so you'll have to do with bottled water. I want to welcome everyone to the June Regional Housing Forum. I can see summer has begun and half of you are at the beach today, but we appreciate the folks who are here. Today's meeting is focusing on health and housing. And I have to say, we work between meetings for 3 months, have lots of planning. This one was more challenging than some we've had. And I think for all of us, we've got a lot to learn about what is the relationship, and I think we will learn that today. So thanks again for being here. Just as a point of personal privilege, I want to just take a moment at the top of the meeting to remember someone that many of us know in this room, Hattie Dorsey. She passed away on May the 25th, just a few days before her 85th birthday. And I can just look around the room and know that a lot of folks knew Hattie, learned from Hattie. She was a pioneer who blazed trails on the front lines of affordable housing. And I really mean that. Back when Hattie started work here in Atlanta, we had none of the conversations that we've got today. She graduated from Clark, Atlanta, and worked on the West Coast, doing some very important work. But our Mayor, Maynard Jackson, welcomed her and put her to work when she came back to Atlanta. She was the vice president of the Atlanta Economic Development Corporation, which today we know as Invest Atlanta. And then, as we said, we've really got to have an organization that focuses on affordable housing. Hattie was tapped to be the founding president and CEO of ANDP, Atlanta Neighborhood Development Partnership, who's one of the organizations that helped sponsor this forum. She was tremendously impactful. She promoted the concept of mixed income communities, led the charge to renovate thousands of affordable apartments, and maybe most importantly, she mentored many of us in this room. And I think especially she mentored a group of young leaders back then who are some of our biggest leaders today. She was a pioneer, she was an advocate, she was a mentor, she was a force of nature. And one of the things that she is known for is she persisted. She didn't take no for an answer. I've been in rooms where I wanted to crawl under the table when Hattie was speaking truth to power, but that was her role, and a very important role. So let's just take a minute to remember her, and also to remember that somebody got all of us in this room and the mentors that we have all had, and to always remember that we don't work alone. Okay, thank you. I wonder if there's any announcements in the room? Any meetings? Must be something happening by September after the summer months, but okay, one in the back, and just tell us who you are.
Good morning, everyone. I'm Andy Schnegenberger. I've been working recently with advocates in DeKalb County. Some of you were probably at the House ATL convening a couple of weeks ago. You also may know that there's a runoff for the CEO position as well as one or two of the commission district seats. I believe I now have clearance to announce this, but there will be a CEO candidate forum on Thursday, June 13th. So before the runoff election on the 18th, featuring, I believe we have commitments from Lorraine Cochran Johnson, candidate for CEO. Also, I think candidate Larry Johnson may be in the process of confirming his attendance, but we also have both candidates for the District 4 runoff for the commission seat for District 4. It'll be in the morning at Frontline Responses offices on, I believe it's on Candler Road. Clearly, I'm a little bit short on the final details, but look for an announcement about that in the coming days. Thank you.
Thank you, Andy. And we really do need to show up. So if you'll get that information to George, we'll get it back out to the group. Maria?
Yes, Maria Supporta, the Atlanta Press Club is having the CEO forum on Sunday, and it will air on GPP. I believe it'll be on Monday's airing, and it will include the two CEO candidates in the runoff. And I also wanted to say there's a service for Hattie Dorsey on Saturday morning, and I don't know if you could provide details for those of us who'd like to go.
Yeah, the visitation is going to be Friday at Willie Watkins in the West End. This information will be at that website later. The funeral service is on the website right now. It is Saturday at 11 a.m. at Lindsay Street Baptist Church.
Thanks, Maria.
Good morning. I'm Natalie Kaiser, Executive Director of House ATL. I just want to let you know the next House ATL member convening will be August 14th. It'll be at the Gathering Spot, and we'll be focused on housing trust funds and on new federal funds for energy efficiency improvement. So I hope to see many of you there. If you're not on our list, you can give me your card after the meeting. House ATL, Georgia ACT, and the Coalition for a Diverse DeKalb and the NAACP of DeKalb are the sponsors of the forum on June 13th that Andy was mentioning. It'll start at 8:30 and go till 10 at Frontline Response. And an invitation will go out either today or tomorrow from House ATL to our member list.
Thank you, Natalie.
Good morning, Sarah Patnod. I'm with the Atlanta Women's Affordable Housing Network. Next week is the first annual Women's Affordable Housing Network Summit. It's here in Atlanta. More information is at wahnetwork.org. And along with that, the Atlanta chapter is hosting Drag Bingo on Tuesday night, which will be lots of fun. It's $5. All proceeds go towards the Trans Housing Coalition. And you can find information about that at atlantawahn.org.
Thank you. We got to have some fun, don't we? Can't work all the time. Anything else for announcements? Okay, why don't we get started? As we all know, housing can impact a family's health through poorly built or maintained dwellings, lack of access of clean air, quality schools, health care, and other resources. We know this is particularly true around childhood asthma, having unhealthy places to live. I know I just had a conversation with James Marlowe at South Face. They're really leaning into this work. And that's really what we're focused on today. In fact, research has shown that housing conditions and access to services may account for as much as 80% of a person's health status. Where we live and how healthy we live affects 80% of a person's health status. A recent survey of the nation's mayors indicates that housing affordability and homelessness are at the top of their concerns. Finally, housing affordability is increasingly a problem to all sectors in all regions. The healthcare sector understands and appreciates the role healthy housing plays in positive health outcomes for families. In Georgia and across the nation, healthcare sector has made investments in affordable housing. And we're going to hear about both some of those commitments that have been made here and some of the investments that have been made. So we want to talk about some of these investments and barriers preventing deeper collaboration and investment. Now, the way we want to start this meeting is a little different than we have in the past. We found a study out of a group called Convergence out of DC that was tremendously relevant to our conversation. They've been working on this for about a year. So we're going to start with an interview that I had with Stuart Butler, who's a senior fellow in economic studies at the Brookings Institute. Until 2014, he was the director of Center for Policy Innovation at the Heritage Foundation. He's a healthcare analyst and a commentator. He's also written extensively about the urban policy and welfare. He's also an adjunct professor at Georgetown Public Policy Institute. I began the interview with really asking Stuart to say something about convergence. And I think it's a model that many of us haven't heard of in Atlanta, but something that we might really try to emulate here of creating the table and doing deep listening. So if we could cue that up, we'll begin.
I want to welcome Stuart Butler to our Regional Housing Forum, our June Forum 2024. Stuart, as we've talked about before, this is kind of where the conversation about affordable housing happens here in the Atlanta region. And we typically will take a topical issue, but part of our purpose is to make connections between transportation, health, education, and the kind of things that hopefully affect our ability to develop affordable housing. So we've invited you here because you have been part of, I think,
to use professional facilitators to get people who sometimes disagree quite violently over certain issues to begin to see each other's position and then come to agreement. Sometimes we joke that this is really a bit like couples counseling for policymakers. And we've done it on a number of different issues like guns and suicide. You can imagine some of the issues there. Preparing prisoners for successful release, care of older adults. And sometimes the differences between the stakeholders are political and philosophical, but sometimes it's just they don't know each other. And I think that's very relevant to this issue of looking at how to get different sectors to work together, because all too often people from one sector, say housing, just are not familiar with all the various pressures and the strengths and weaknesses of, say, the health sector or transportation. So often they talk past each other and they get angry with each other because they can't understand why the other person can't see their point of view. So it's really important to get people together, and that's what Convergence does. And it very much builds on my other work, which is at the Brookings Institution here in Washington, where I've been focused very much on the whole issue of so-called social determinants of health. All these other sectors like housing, transportation, nutrition, that influence health. And so how can we get a better health outcome by actually designing policies that address some of these determinants or drivers of health? That's mainly what I have been working on for the last 10 years.
Well, and as I have been involved with Convergence and tracked it, I feel like we have a lot in common. We take a much lighter touch with the quarterly meeting, but I know how important language and framing and taking time to listen to each other and find common ground is. I know Convergence recently released a report on shared interests on health and housing. In the report, it says some research suggests that housing conditions, available social services, nutrition, and other social factors account for as much as 80% of a person's health status. So tell us about that report. I know you're still in process, but very relevant for the conversation we're going to have today.
Yes, well, the report that you mentioned is really, it's a good example of the kind of interim report that we do in the Convergence process. And it touches on housing and health, but also touches on social services and their role and nutrition and so on. I think we've discovered from experience that if you want to find answers to a problem, probably the first thing to do is to agree on what the questions are that you're trying to answer. So what we did in this particular project, as we do in others, was to begin by getting groups of people together, including people with lived experience and so on, for a series of what we call brainstorming sessions to really try to identify what are the questions that have to be answered if you want to create the best policy environment to encourage different sectors to work together to improve community and household health. You've got to figure out what those questions are before you can move to answers. So often people jump to try to get answers first before everybody's agreed on what the questions are. So these brainstorming sessions provide us with a background and an understanding and a sense of where people are coming from, as Convergence as an organization does. And it helps us find the main themes that are on people's mind and the main things that they feel need to be answered. And so this report is that kind of interim report, which is really not the answers at all. It's stressing the themes and stressing the questions that really have to be dealt with. And really, just quickly, there were really 4 themes that came out of these sessions with regard to social determinants of health. One is taking active steps to improve opportunities for collaboration across sectors, looking at laws, rules that get in the way, and so on. Secondly, making sure that the financing, in other words, the payments made to organizations, the payment systems are in line or are aligned with the objective of getting them to work together. No simple thing, by the way. Also looking, thirdly, at data and evaluation. We've got to know whether, when we take an action, whether it's actually working. So often in these areas, we think we know what's going on, but unless you get good data and can develop that data and evaluate it, you sometimes go down the wrong track in terms of trying to solve this. And then last but by no means least, there was a strong emphasis on developing a workforce across sectors. We heard over and over again, it's nobody's job to do this, right?
Right.
And so it's very difficult to do that. So we looked at various types of workers, like community health workers, social service workers, and so on, say, how can we help enable those workers to actually be effective coordinators to bring partnerships together? How do we pay them differently? How do we train them differently? So
Well, let
that's
me ask Stuart, you've been doing this for a long time. I know this has been a focus of yours.
Yep.
Would you say that conversation is getting easier or
I think it's
harder?
getting actually a lot easier. It's gone through various phases, I think.
Okay.
If we were meeting here, if we had this conversation 10 years ago, I think it wouldn't be obvious to people that investing in housing might actually improve people's health and so on. So it's taken a long time to get people to understand that. Now I think they're at the stage of saying, okay, we get this, it's important, and we're going to try to do that. And that's people in health, in hospital systems, in social services, food, and so on. And now they're finding that the whole policy environment they have to work in was not designed to encourage this. So we're at this crucial stage, I believe, of saying everybody gets it, but now we've got to create a policy environment that actually encourages this to happen and to deal with the frustrations that people have that are trying to do it now.
You know, and we often talk about that at the housing forum of creating that right environment,
Exactly.
right, where we can have that conversation. I know you have spoke to the need of creating what we call an infrastructure for building trust and creating collaboration and partnerships. I know the definition there was we mean both tangible elements such as information exchange,
Right.
systems, financing, personnel, and so forth. Give me an example of what success in coordination looks like.
Right. Well, first of all, you're right that often you find people who want to do the right thing who just don't talk to each other about it, or their departments don't talk to each other, or their budgets are not aligned to do that. So we've looked at various ways, and are looking at various ways right now in this project because we're now trying to find the answers, and that we'll have a report coming out probably in the fall, where we will see where the agreement is. But they range in a variety of ways. There's so much that can be done simply by departments, A, talking to each other, and B, actually explaining to people in the field what they can and cannot do. All so often, we find that people in the field are saying, I'm not sure if I can use Medicaid to do this, or I'm not sure if that housing money can be used this. They call up the departments, and sometimes if they call 3 auditors, they get 3 different answers. Right. So then they say, well, I'm not going down that road because I don't want to literally break federal law by misusing that money. So number one, in terms of effectiveness, is really to look at providing guidance and both to the departments and to people in the field. And that's happening. We're seeing the federal government especially. In fact, just about a year ago, or just less than a year ago, they published a so-called playbook for states and for localities on what can and cannot be done to get different pots of money from different programs to work together.
So who would have access to that? With the hospital groups, insurance companies?
Yeah, I mean, this is all available online from the federal government, and then it's really aimed and sent to field offices, to states, to county governments, and to organizations in the field. So everybody can see on paper what they can actually do and can't do. That's a really important a step forward. And then I'd say the second thing is quickly, I would just say secondly that aligning budgets in this area is really important. So often it requires spending in one department to actually benefit another department. Think of housing. If the housing department, say the public housing authority in an area, improves the safety of bathrooms in elderly housing, you're going to reduce the numbers of falls and people being taken to the hospital and have hip. Medicare is what benefits from that. The housing authority gets no payback.
Well, this is a place, Stuart, I wanted to ask, because you also talk about partnerships are often weakened by the wrong pockets.
That's right.
Right? It exists when one sector needs to invest in a way that benefits another sector, but offers little or no direct cost savings to the first sector.
Right.
This seems relevant in that we're going to talk about this later at the forum, is not many years ago, our hospital groups made a commitment in this area. But the question of out of whose pockets and who benefits. So in our case, a lot of these hospitals are nonprofit groups. The benefit should be the community, right? Speak a little bit about the wrong pockets problem and how you talk about that.
Yes, well, it is this general problem of sometimes one sector is ideally placed and really should take the initiative in addressing an issue, a social determinant of health, but they don't get the benefit financially of addressing that issue. It is like reducing falls and then Medicare benefits. So first of all, you've got to look at, are there ways of changing the budget process at a certain level of government, in a sense, to give credit to the department that takes the initiative. So for example, in housing, you might add some funds from, say, the Medicare program, which of course is a federal program, or Medicaid, to housing, to say, we want to give you the incentive to do what you guys can do, which is go in and actually make changes in these units. And in that way, give an incentive to do that. Another thing which some counties in particular have done across the country is to look at different departments that may benefit from an initiative, a sort of a shared initiative. So maybe nutrition might be an example of that, or social services, and say, well, let's essentially take some money, this is the county speaking, or the state, from each of those different departments, put it together in a pool, and use that money to finance whoever it is best placed to take the action. So that way, it's almost like, for want of a better word, a tax on each of the departments to say, this is something which is a common problem. Let's create a common pool of money and use that to finance whichever department is best able to take that change. And that's happening states like Virginia and Ohio and elsewhere.
So Stuart, you and I could talk about this for several hours.
I'm sure.
And we did talk about it on time. I have limited time today. We're going to continue to track this. We're going to make this first report available to everyone and encourage people. We're going to continue to have this conversation. So this is the beginning of a conversation for us here in Georgia. Let me just ask quickly, what recommendations would you give us at the housing forum or to the larger community about staying at the table, building trust?
I think there's some pretty specific steps that are really important. I think one thing you can do, certainly, by the way, is look at the Convergence site. That's convergencepolicy.org.
Right.
Because in addition to reports there's also sections on the process itself that we use. So it'll help people see the kind of process. But I think it's very important to have brainstorming sessions at the beginning to say, look, we're not here to get everybody to agree right now. We're just here to hear you about what's going on, what are the issues. That's what led to this report that you mentioned. Those brainstorming sessions. It helped everybody begin to understand where everybody's at.
And that everybody feels heard.
Everybody feels heard, and you get to hear this. Then I think, second, it's very important to get decision makers from each of the different sectors in the same room for several occasions, just to start the discussion of collaboration. I really recommend you do that over dinner if you can. Make it a social thing. I mean, have some wine. I'd recommend California Pinot Noir. It's a very good wine for getting people to
well,
talk.
You're talking to a food guy here, Stuart, so you don't have to convince me.
But it's very important for people to know each other. So often people come into a room and they see somebody from the insurance industry, or they see somebody from the hospital center, and they just assume they know this person, and they assume they know what they're all about. Well, they don't. And so getting them together, you get all kinds of insights, and you begin to see each other as people and start to talk in that way. And then next, it's important to listen. Listen to all the frustrations first. Listen to everybody's position before you try to solve any of the problems. Only when you've done all that do you start talking about solutions.
So that's the beginning of the conversation.
That's right. It's so often often, and we see this in Washington, you try to jump to the answers first. And nobody, first of all, nobody's agreeing on what the question is.
Right.
Or they're all coming in with sort of preconceived views and so on. So it's very important to do this work of listening and getting, and then we found that very often that leads actually to different answers
Right.
that you would expect when you started. And I found out myself, I work in this field a lot. But it's also often we find certain things matter to people more than I thought. And certain ways forward are more effective than I thought. And things that I think are great steps forward, just are not going to fly with certain people.
All right, Stuart, I promised
Okay.
that we would come back to you. We're going to track this. I'm going to encourage folks to get involved, and we remain committed to following these best practices. Thank you for taking the time to be
Thank
with
you,
us,
and I
for
appreciate the
you've
work
done
you're
through your
doing.
lifetime, and
Sure.
thank you for the work of Convergence.
And thank you for your work.
All right, thank you.
Bye-bye.
I hope that was helpful in framing our conversation today, and I would really encourage you to go to convergence.org and follow this study, but also learn about their process. I mean, one of the key things I heard is we often don't know each other. We can make assumptions about each other or assumptions about each other's organizations, but often don't know each other. The other one I heard is we've really got to figure out what the questions are before we get to a solution. And I think we've learned that the hard way. And then finally, it's no one's job. And I know, Jack, you've run into that working with the homeless and with the Partners for Home. We get everybody around the table and we go, well, it's not my job. My job is this. So what we're proposing, and I think what the regional forum represents, is that table where we get to know each other, where we really try to focus on the right questions, and where we can drive action. In December 2019, the Atlanta Regional Collaborative for Health Improvement, ARCHI, coordinated a pledge from 6 major healthcare organizations operating in our region. In their public pledge, senior executives from Grady Health System, Kaiser Permanente, Piedmont Healthcare, St. Joseph's Health System, Mercy Care, CareSource Georgia, and Wellstar Health Systems committed to leveraging their resources, influence, and expertise to support affordable housing efforts across the region. These health systems will further explore ways to integrate healthcare services into affordable housing solutions, with the ultimate goal of improving health outcomes for patients, employees, and the community at large. So the commitment was made. We're going to hear today where we are in those commitments and the work that's left to do. So I've asked Jeff Smythe, who I think we have all known in various leadership positions. He is the executive director of ARCHI, to update us on that pledge and the work that ARCHI is doing. Jeff, thank you for being here, and you got the mic.
Morning. Great to be with you. I've been a fan of the forum here for many years, and great to see many familiar faces, particularly from the time that I spent working with our unhoused, and wanted to shout out LaTanya over here that worked closely with me and with our team when I was at Hope Atlanta, particularly in the heat of COVID hitting us in April of 2020, when we were working together collaboratively with the Healthy Hotel, and I'm seeing Jack here, and all the work that took. So great to be with you and to see these familiar faces that have been at this, and learning together, right? The learning that we did by seeing crisis, seeing those who have been kind of left out of good care, those who were coming to the airport for shelter every night because there was nowhere else to go. and then working collaboratively to solve that together. So we're taking learnings from that experience in my time at ARCHI to invert the burden. So what do I mean by invert the burden? So I want to go into this hospital commitments, what we learned in 2019 and where we've been since, but I want to set a little bit of the stage. Stuart did a good job of that for kind of what ARCHI's been up to. And it's not lost on me that I'm standing up here saying something that this room already knows, right? I know that we're preaching the choir when we say that health and housing are inextricably linked, right? This is known now, right? We are never going to get better health outcomes across Atlanta if we don't have more affordable and accessible and livable housing. Not going to happen. Okay, so we know that. But we also know that the more that we're in silos, the less coordination of care, the poorer health outcomes as well. And it's not just health and housing, is it? Right? It's all of those other social determinants that Stuart talked about, right? We're talking about education. We're talking about transportation. We're talking about economic opportunity and employment. All of these different sectors, when we silo them, and we understand why we have to silo, right? We got to kind of lean in and perfect in one area. But when it comes to better health outcomes, silos actually do worse for us, right? Silos have set up poor health outcomes across Atlanta. It's also not lost on me that I am a white male standing up here talking to you about health equity. I have come from a place of power, a place of privilege, a place of opportunity that others across Atlanta have not had, simply because of the color of my skin, simply because of the zip code that I was born into. This is a fact. I know that if we are in Atlanta, we think, that's not my Atlanta. I don't know that. That's not how we operate. But our health disparities tell us something different, right? Whether it's heart disease, whether it is diabetes, whether it's asthma, whether it's COVID, our health disparities are telling us we are not having equitable health across the board. In fact, the color of our skin and the zip code we're born into has a lot more to do with our life expectancy than anything else. If you're like me, that's not okay. That is not the Atlanta I know, and that's not the Atlanta I want to be a part of. And what we see is a dramatically different life expectancy for different parts of the same counties, different parts of the same cities. In fact, we see here, this is more recent data from ARCHI, 63.6-year difference to 87.2. Many of you have seen this before. This is nothing new. I'm seeing wonderful, familiar faces in the crowd here. But this is not okay. And so out of this, we have to say, how do we do better? How do we invert the burden? How do we think about those who have been most marginalized, who have had the least access around diabetes, around COVID, around asthma, who have seen disinvestments in their community, whether it is after the Great Recession or even recently with hospital closures? How do we manage these same communities that have experienced redlining and disinvestment through interstates that carved through them? The same exact communities that we're seeing dramatic health disparities. So this is where ARCHI's context comes from, and this is where a group of about 70 organizations came together about 12 years ago and said, this is not okay. And even what we've seen recently, we're saying this is not okay. And we can do better, but we need a collective impact model. We need a way to come together and collaborate. And so ARCHI has now been at this, like I said, for about 12 years, and you can see our mission statement there. It's really looking at how do we invert the burden, how do we do that over multi-sectors, and how do we do that in a way that drives sustainable change to our systems, not just the health system, but to our systems, right? Because they're all inextricably linked. We really adopted that collective impact model that we are not into direct service ourselves, but we work with all of the health systems, the payers, and a large group of community-based nonprofits that are focused on that direct service. There's also a focus on data and evaluation, as we heard from Stuart, very important in any collective impact and any collaborative model. And so what we've been at is invert the burden in terms of changing the mechanics to the system. How do we do that together, right? And how do we do that in a way that's actually going to be sustainable? How do we spark change in the system where we're not seeing change happen fast enough? And how do we expand resources to scale? So we're going to do a quick video here just so that you know what I mean by invert the burden, and very quick video.
Good health requires more than health care. Quality education and jobs, affordable housing. Good health requires more than health care. Quality education and jobs, affordable housing, safe communities, and access to healthy food are essential to health and well-being. Atlanta has resources, yet many of our health outcomes lag behind parts of the United States and the world. Why? Because it's far too difficult for far too many to access what they need to be healthy. The burden of navigating disconnected services falls on the person in need. If Bethany needs help with rent, she might have to apply to 5 or 6 different agencies before getting aid. But Bethany also needs support for food and after-school care for her kids, and an appointment to monitor her diabetes, and, well, the cycle of applications and eligibility starts over again for each. Even if Bethany manages to break through all these barriers, she still may never actually connect to the services she needs. Health is only achieved when socioeconomic factors are stabilized. But the path to getting there requires too much from those in greatest need. The challenges are even greater for Black people and people of color in our community. There's a better way. We must invert the burden away from those in need. When the person or family in need is at the center, processes are designed to meet their needs. Administrative work for agencies that deliver care is reduced and streamlined. And Bethany can stop chasing down the services she needs and focus on stabilizing her life and her family. We design the system we have. We can redesign it, and we must start by meeting people where they are, coordinating care, and inverting the burden. Join us as we work toward a brighter, healthier future.
Had multiple chronic conditions and is scoring high in terms of those social needs indices, right? So when we do social needs indices, this is around what is their housing situation, what is their food situation, et cetera. If they're scoring high on that, do we just hand them a piece of paper that says, here are the organizations that can serve you, right? That's kind of been how we've done healthcare, hasn't it? It's like, we're done at the doctor's office, we're done at the hospital, here is a list, go to it. So those who are most burdened are going through the spaghetti map to try to get the services they need in a time already of crisis, right? And so what we tried is these community resource hubs, right? And what this does is place the care at the center, place those families, those individuals at the center, pairs them with a community health worker. You heard of that already, a community health worker. This is something that has been with us for many years, but finally getting the attention it needs. I'm looking at Christine Wiggins over here with the Fulton DeKalb Hospital Authority that's been a champion for community health workers. Place a community health worker in the middle with lived experience, with community connections, and place them with those individuals with chronic conditions who have been traditionally housing insecure, food insecure, and you will see dramatic results. But also ask the health system to embed this community health worker in their system so that they're able to talk to the full care team. And then also ask nonprofits that are focused on different social determinants of health. Sometimes they're in their own silos simply because of the work. Ask them to come together and to share data and to share information and to work collectively toward moving those individuals, those families that are placed in the center with the community health worker with the services they need. And what are we seeing? We're seeing great results. Dramatic reductions in emergency room visits, dramatically better blood pressure numbers, dramatically better BMI and A1C numbers, and more access to nutrition education. We're also seeing more healthier days. Like this is a screening that many of our community health workers and medical teams are also screening now. More healthier days, more feeling like I'm in control of my health care. And so with that context, we've leaned into housing as health, right? How does housing interact here? And there's two areas that we've really looked at. One is can health systems actually think through their investment process? How can they think through their housing and their workforce, right? When they think about housing, it's not just for the patients that are coming frequently in and out of their emergency departments, but also it's thinking about their workforce who is having a harder and harder time finding housing appropriate closer to the different hospitals, healthcare settings, et cetera. The other way that we leaned in was collaborating with House ATL and working on a rental assistance pilot where we've been able to work with rental assistance nonprofits that are focused together and really reduce the burden for those. We're not going to spend as much time on that today, but let's talk a little bit about what we learned in this process with the health systems, right? So yes, we, as Bill talked about in 2019, Grady, Kaiser Permanente, Piedmont, Mercy Care, CareSource, and WellStar all signed a pledge together and said, we are going to commit to developing a joint investment and addressing housing together. And then what happened? Pandemic, yes. And so it has been a little bumpy, I would say a little bit bumpy. We are going to hear from a couple of our health systems, a couple of our partners with some really amazing, I would say revolutionary work that's happening right here in Atlanta that you'll see where they are actually standing up housing themselves. They're doing some pretty incredible work. And we've had different levels of engagement and different abilities to kind of move the needle. We do know that the workforce situation has changed dramatically for our health systems. And so we see this as a marathon, not a sprint. But we also saw some pivoting that we could do during COVID and some convening that we've been able to do with health systems, continuing to think through all of the different housing options, particularly for developmentally disabled and behavioral health patients who oftentimes were not able to kind of move out of the hospital setting in an appropriate time frame. So as of this last year, we had some great updates from Kaiser Permanente, from Mercy Care, from CareSource, from Humana. We also invited philanthropy to be a part of this. And I want to shout out Woodruff and Whitehead Foundations. They have already been recognized, I know, in this format, but they have stepped up as well and said, we see how much housing is going to be important. Other foundations like Jesse Parker Williams saying, we see how important these hubs are and the intersection of health and housing. But you see some pretty exciting investments here from CareSource, from Humana, from Kaiser Permanente, from Mercy Care. I'm not going to steal thunder of my colleagues, but there's some pretty cool things happening right here in Atlanta. Some building that's happening, and I'm not going to dig into that too much. But my colleagues here are going to talk about what Mercy Care and what Kaiser Permanente are up to. Some national examples that I did want to share as well, because we've got some really great national examples of investments, right? So Bon Secours Health System out of Ohio has been working on just taking 1% of their investment portfolio. We're not talking about like a big donation. We're talking about your investment portfolio at a health system and putting 1% of that into housing investments, right? So you're still getting an ROI. It's just not in that traditional investment portfolio, right? And we're seeing these health systems saying, yeah, we can do this and we can actually help stand up housing. You can see in Bon Secours really investing in the CDFIs, the Community Development Financial Institutions. Here's Intermountain Healthcare out of Utah, Idaho, et cetera. And they've allocated 2% of their investable assets into impact investing. I want to give credit, by the way, to Healthcare Anchor Network. They are the ones who have gotten us all of these wonderful national examples. ARCHI has not. ARCHI's focused locally. But we're seeing some great national examples all over the U.S. Setting up a place-based private equity fund. Utah Housing Preservation Fund, $4 million deployed to prevent subsidized and naturally occurring affordable housing from being converted into market rate rentals. So standing up 491 units. Here is UMass Memorial Health doing a lot of innovative work. And committed to deploying $4 million of their investment portfolio. They're also working with this Worcester Common Ground, which is a not-for-profit CDC, so kind of direct investments from health systems into CDCs, into local nonprofits, in some cases even into for-profit entities, whatever it takes for them to get more housing stood up. UMass Memorial Health has also done advocacy with their local government to get more ARPA funds into affordable housing. So you can see where health systems can also say, it's not just about standing up housing or even just putting 1% of our portfolio. We can leverage our advocacy strength and get more dollars into affordable housing. Westside United in Chicago, another example, and certainly Dartmouth Health in New Hampshire. Lots of different examples nationally of how health systems, payers, all of those involved in providing health can think about their healthcare, think about their portfolios, think about their investments, and think about how they can invest in affordable housing. So what's next? Well, we do see in our Invert the Burden work to continue to have these conversations with each health system. There were some health systems you didn't hear about on there. We're in conversation with them still, right? Saying, what can your investments look like? What does that look like? We know, again, that this is a marathon, not a sprint, but we are actually wanting to see some more results, right? So we're working with each of our health systems on what they can do differently, or what they can add to their portfolios. Our rent, mortgage, and utility relief collaborative, that continues to have a lot of learning, seeing dramatic reductions in the time it takes for those seeking rental assistance from 20 hours of seeking assistance on average to roughly like 6 minutes now to enter information into a portal that they can use at any time of the day. Don't have to go to all these different nonprofits to enter their information. They can go to one portal. But we have a lot of learnings there in terms of really illuminating the lack of enough subsidy, right? Now we are seeing across the board 18 organizations that have been involved with that, but unfortunately only a small percent of those that need rental assistance are able to receive it, even through this collaborative. So we're seeing a dramatic need for more advocacy around more funding for subsidy. These are all the different partners that have been at the table with us, whether it is in the Rental Assistance Collaborative, whether it is in the Community Resource Hubs Collaborative. But you can see local collaborative, this is what's happening. This is all of those that it's taking to move these needles together. Other piece of Invert the Burden we see going forward is continue these conversations with each health system. Continue to look at community foundations, Grow Fund, and other kind of pooled investment funds that can be really easy to work with. And so those who are doing these investments don't have to worry about good return. They can just work with community foundation for that. We think policy, continue to lean in on policy is very important. We heard that from Stuart earlier. A lot of policy around community health workers was brought to the legislature this year. I shouldn't say a lot. A very important bill was brought to the legislature. It did not get passed, but we have our eye on that, and with partners like Georgia Watch. And continuing to make sure that policy is thinking about the interaction between health and housing. Medicaid expansion. If we don't think in this room, those of us that are thinking about housing, that Medicaid expansion matters, then we're wrong. Medicaid expansion, we were close this year, weren't we? Yes, we were close this year. It will make a difference. Think about those who are stressed with housing. If they actually have insurance now through Medicaid, less stress in their day-to-day life. Still stresses around housing, but less stress around healthcare, right? I'm not saying it's easy, I'm not saying it's a magic wand, but we do think Medicaid expansion will make a big difference. Other pieces of Invert the Burden that we have to be thinking about. We've got to be thinking about more recuperative beds, and there's a wonderful collaboration in town that's working on that. Housing-centered hubs. Star C has been at the heart of that, working on a housing-centered hub with us. Continue to work with each health system and their housing goals, and then, of course, interoperability. How do we get data sharing, not only across health systems, but across health systems to the nonprofit sector. Last but not least is really making sure we continue to center those lived experiences and those community voices. If you've not been to ARCHI's website, we did a deep dive with those who were unhoused. We call them archives. Some people say archives, but we're using the word ARCHI to spell archives. And the whole idea is to give you an opportunity, give each of us an opportunity to hear from those who are unhoused, those who have experienced homelessness, and to just hear their stories. Sometimes it's just centering those stories in what we do. And our work has continued to kind of center those stories and say, how do we continue to move the needle with these health systems by centering community voice? Thank you.
Thanks, Jeff. George wanted me to remind you that these slides are available at the Atlanta Regional Housing Forum website. So you can find all this material. Jeff, we would take 20 minutes of questions, but we're not going to do that in the interest of time. We're going to bring the panel up, if the panel would come up. I would just make note that we can't say that we don't know what to do. We can't say that we don't know how to do it. There's models in other parts of the country. There's some things that are being done here in Atlanta. So part of today is to encourage us that we're not flat-footed, things are happening. But I thought if you were going to mention marathon and sprint another time, Jeff, I was going to jump up and say, I'm ready for a sprint. Well, we are in a marathon, and we live in the meantime. But this is something very important, and really in the history, I think, of the Housing Forum, because we really haven't made this point so poignantly in the past. So let me thank the panel that's going to be here, that is here. We have Stefanie Hurst from Kaiser Permanente. We have Steve Siler from Mercy Care, and Jeff Smythe, who we've already heard from. I'm not going to go through all where they went to college and how many kids are at the beach right now, but I'm going to ask them to introduce themselves as we go along. Well, maybe we'll just do that right now. Just before I kind of get into any questions, let's just go down the line. Stefanie, just tell us about yourself. I know you've been at KP for about a year, but you worked for many years at Grady, so this is not a new subject for you. Tell us about yourself.
First, yep, it's on, okay. That's the first thing I wanted to tell you about myself is the mic on or off. Good morning, everyone. Thank you for taking the time. So as Bill shared, I was at Grady Health System for just shy of 10 years in the community outreach and community affairs space, working heavily also with what is referred to as community benefit, which handles the social determinants of health that we've talked about this morning, et cetera. And post-COVID, things shifted at Grady like they do many places in the world. And I made the migration over to Kaiser Permanente. And I made the migration for the same reason that I chose Grady, and that is mission. Kaiser Permanente is incredibly mission-based and innovative as healthcare systems go in all of the spaces that have been discussed today. So I won't talk about college or my dog or that.
Steve?
Steve Siler. I'm the Chief Development Officer for Mercy Care. I've been in fundraising for about 25 years with various nonprofits in the Atlanta area. Mercy Care, if you don't know us, I imagine most of you do, but Mercy Care provides health care in clinical settings, fixed site clinics. We have 4 fixed site clinics. We have mobile coaches, and we also provide street medicine services among a host of other wraparound services. Primary care, behavioral health, dental, vision care, for a patient population that's uninsured, underinsured, and in some cases unhoused. About 50% of our patient population is unhoused. I'm proud to report we'll be reaching numbers we'd never seen before. We'll have more than 80,000 encounters with over 16,000 unique patients come the end of this month. So we're really pleased with the way things have gone post-pandemic. We've finally been able to get staffed up and deliver the promise to the community that we hold sacred. So it's a pleasure to be with you.
And Jeff, you've been introduced, but would you like to say anything? Okay. Well, let me just begin, and then we're going to open it up to the audience. Stefanie, I think all of us who have any dealings with health care really rely on Kaiser Permanente for data. You guys have done that, particularly in California, but what are you doing here in Georgia? You have a growing presence. You're here today representing them. Tell us about the work here.
Yeah, so a lot of the work here aligns with what Jeff had discussed, again, those social determinants of health. What I personally and professionally am drawn to in Kaiser Permanente is, again, that innovation. It is still rare, even though we are manifesting in this direction and evolving in this direction with healthcare systems, but it is still rare to find a healthcare system that at the core of the person care is economic development, climate, food as medicine, housing, violence prevention, and all of those things are at the core of the Kaiser Permanente model. Not only for the member, not only for those that we insure and serve, but for the entire community that we serve. So we invest in places that we don't even necessarily have membership, which is also very impressive for a healthcare brand. And what we're doing in Georgia aligns with all of that. We have a national base in Oakland, California. And so everything we do, our investing, our community investing, our charitable healthcare coverage, which is actual coverage that Kaiser shares with individuals who qualify, who would otherwise not have health care, all of our grant making, it aligns throughout what we refer to as the enterprise, so the whole organization. And so Georgia is reflective of that. And then we also have in each of our markets what is referred to as unique market need. So we specifically align to things that we find as specific issues in Georgia and in Atlanta with what we support from a charitable giving perspective. So it's all of the innovation. It really aligns beautifully, hence our strong collaboration with ARCHI, because everything that is in the Kaiser Permanente mission is all about what Jeff referenced earlier. With those social determinants of health, Kaiser Permanente deeply believes, again, as discussed earlier, that you have to have housing for health. Housing is health. If you do not have a home, you don't care about your flu shot, right? You didn't care about your COVID shot. It's hard for you to take care of your child, and certainly you're not thinking of preventive care, which again leads to that vicious cycle we're in this country, which I experienced more at Grady than anywhere. It's that frequent user of the emergency department because they have not known a life of preventative care. And that's what a home leads you to. It leads you to preventative care and overall health care.
So I know that's a strong commitment of KP is preventive care. How would this show up? I mean, you've got an active foundation that's making investments. Would we see, if we went to the website, to the foundation, would those investments reflect what you just talked about?
So glad you asked, Bill. It's like I gave you those Krispy Kreme donuts we were talking about.
Well, you better have a good answer to this.
To incentivize you. I've got such a good answer. So I'm just shy of a year at Kaiser Permanente again, but I'm so proud to share that in the Georgia community directly, we invested $53 million in the year of 2023, and we know, because we are so data and metrics based, that we impacted 1.4 million individuals in the state of Georgia. Yeah.
Good. And that's just the beginning. Steve, tell us about the work of Mercy Care.
Sure thing. So I want to talk about our recent partnership in a housing development at our Decatur Street clinic. But the genesis of that really goes back to around 2013, 2014. My previous boss, now retired, Tom Andrews, was leading the charge in building a new clinic in Chamblee. He was also committed to providing some affordable housing on that clinic site. Found a 4-acre parcel, developed our clinic. We raised money and built our clinic out in Chamblee, and then sold a portion of that parcel, a little less than 2 acres, to Mercy Housing. There's now about 80 units of affordable housing at that site. The success of that, and it was billed as kind of a health and housing partnership, is what spurred the development at Decatur Street. At Decatur Street, where we just 2 years ago finished an expansion of the clinic there, we had an additional about 4 acres. We were committed to finding a partner, and we did. and have had a very successful partnership with Penrose, which is affordable housing and developer out of Philadelphia, but has a footprint in around 15, 18 states, including Georgia. Penrose has been key in helping us to, and a shout out to Eamon Martin, who's here in the third row, regional vice president for Penrose here. Anyway, we partnered with Penrose to develop two parcels. Phase one is 170 units of affordable housing that has mixed affordability. Phase two, and those 170 units, we're expecting to have residents in there in August, so just a couple months. And then phase two, we're developing an additional 80 to 100 units of senior housing, which we anticipate being finished coming online sometime in 2026. Mercy Care has a 20% stake in that partnership, which has had certain benefits to us. We did negotiate a ground lease on that deal, which enabled us to get about $1.7 million up front that helped fund our clinic expansion. That was a key part of the deal. And, well, let me talk about I think one of the, I'm no affordable housing expert, but I've read
you are today, Steve.
Well,
Go ahead, yeah.
I've read enough about sort of beltline developments and fails around affordable housing that I know that what we seem to be offering with those 170 units is incredibly committed. There's 30 units, and Eamon can correct me if I'm wrong, 30 units of 80% AMI, about 100 units of 60% AMI, 30 units of 30% AMI, and then we also have 10 units that Mercy Care controls and is leasing back from the partnership that we're going to have for respite housing for our patients. So that'll serve as transitional housing for patients that we want to, that have need of getting immediate housing. So it's really exciting in that regard. The other thing about this development is it's located very close to amenities that'll add value for the residents. It's right next to Selina Butler Park. The MLK Recreation Center and Auditorium is just across Borders Avenue or Borders Street, and then the MLK MARTA station is right there as well. Not to mention the Mercy Care Clinic, so if some of the residents choose to make Mercy Care their medical home, they can do so.
All right, I'm going to do something unusual. Eamon, I didn't set you up for this, but I'm going to call on you right now. One, I want to know about, is this something that Penrose may do again? Is this a model? And two, how do you make the numbers work? That's the big question, right?
Well, newsflash, I don't have the secret sauce. I've been looking
I'm
for
going to take the mic back then.
No, but let me start with good morning, everyone. And Steve, you covered everything great, and I want to say there is a secret sauce, and you're right. Making the numbers work today in today's world is 99% of the challenge. I tell people I spend the majority of my time knocking on doors, really trying to get funding and support for these projects. And so what the secret sauce really, well, let me back up. Would we want to do this again? Absolutely. I mean, this, even though it's, we're just about to begin to lease up, but we totally believe this is going to be an incredibly successful project. As you heard, Steve covered the income mix that we have here, the amenities that we have, rooftop deck, we have views of the downtown, midtown, and you can barely see the Buckhead skyline from the rooftop. So it is going to be an amazing project. But the secret sauce, what does it take to pull something like this off? And one of the things, Steve, just to add to the challenges of this project is, there is a direct connection with the clinic in Mercy Care. In fact, we've constructed a 4-story parking structure where we're going to have a shared parking arrangement with the staff at Mercy Care. And if you know anything about affordable housing, that is a very complex deal to do and makes it more challenging. But what is the secret sauce? I mean, we have probably, I think it's 7 different sources of financing to pull this off. I mean, really the secret sauce is partnerships. And
Well,
it's
here's
it's really Mercy Care. I mean, I'd like to take a lot of the credit for this, and I agree with what you said, Steve, you are an affordable developer now. It was Mercy Care to step in outside of their safety net to become a real estate developer, an affordable developer at that, takes a lot of courage, and to have a partner like Mercy Care, when we went knocking on those doors, because let me tell you all the financing partners, Invest Atlanta, the City of Atlanta, the State Housing Finance Agency, DCA. When you're
Here's what I'm fishing for, okay? When you say Mercy Care was our partner, they brought the land.
Yes.
Right? And that's something we've talked about here at the Housing Forum before, that the city owns land, the school board owns land, Atlanta Housing owns land. So that was a lease. Right?
That's half the battle.
Okay, so that really is part of the sauce of this deal. And as we look to the future, we can try to get better financing, we can try to get support from HUD and federal money, but the land is what makes it work.
Absolutely. Land is half.
All right, I'm going to take you off the hook there, buddy. Jeff? Let me ask you a question. You probably have something already to say, but I'm going to ask a question. 5 years ago, ARCHI got folks, and I'm sure it wasn't easy, around the table to make that commitment. Do you guys meet every month? I mean, how's that going? I know COVID came, challenges there, but to Stuart's point, I don't know if you're doing the Pinot Noir wine deal, but you know, you've got to keep meeting and talking and building trust. Is that conversation continuing?
It is. We need to add Pinot Noir to that. That has not been a part of our secret sauce, but we are. I would say credit to all of our different health systems and some of the payer insurers, because they have continued to meet. We have a Thursday morning call that's just for them. Not every Thursday, but about every other Thursday. And we really focus on what are these breakdowns in inverting the burden? What are these breakdowns in coordinated care? How do we get speakers? How do we get individuals that are working on adult protective services or behavioral health or all of these different breakdowns to help us think out loud together? So that group does get together,
okay.
Bill. The executives of the health systems, we've not had as much success continuing to convene on the housing subject. And we've been asked for a little bit of a reprieve from some. So we're giving a little bit of time, but I think we will continue to ask our health executive folks about their housing investments.
All right, so this is notice to the executives. We want you at the table too, right?
Absolutely.
A question came from someone watching YouTube today, from Roger Vest. What efforts are taking place outside of Atlanta? I don't think they're talking about Columbus or Houston and so forth, but we're really talking about the region. We just focused on a project that was so important because of its location to services and transportation, but I know Stefanie, KP is a regional organization. Jeff, can you speak to that? Other things going on?
Yeah, I mean, what we do see is maybe not a concentration, but certainly what I would call a scattered site. So different investments in different parts of the region. Particularly, we're seeing from Kaiser, we're seeing from Humana, that have not necessarily concentrated one place. Even CareSource has done both an urban and a rural investment in housing in the last couple of years.
Okay. Let me ask one last question, and then I want to turn to the participants here, which I thought was so important. We didn't have time to talk about it very much with Stuart, but it's the wrong pockets issue. So, you know, everybody's at the table with their particular work, right? And they're going to measure that according to the organization they represent. Now, I would submit that most of the healthcare organizations are nonprofit, so the community is the benefit, not just the organization. But you've got to keep those organizations viable. is that a conversation, any of you, is that a conversation when we get together? Stuart talked about the idea of putting a fund together where we all kind of put into that so that the community benefit is what we measure instead of just the benefit of the investors. Any thoughts, any of you around that wrong pocket? Because that's a big one. That's a big one.
I think, to Jeff's point, we work most collaboratively. We work highly collaboratively. Of course, again, it's so often referenced at this stage in our nation's history of the world, frankly, is how COVID impacted everything. So during COVID, it was one of the greater moments of collaboration regionally and nationally between healthcare systems. We learned that in a crisis. We kept the momentum in some regard, not in all. We've kind of gone back to what we knew before COVID. And ARCHI is a huge piece of how, to Jeff's point, those Thursday calls, we are keeping each other apprised of our focuses and where we're investing, et cetera. Kaiser looks less to invest with other health systems overall as far as community benefit goes, but does look more and consistently invest with community partners more. So in the Southeast, and across the nation, we partner with enterprise partners, which is, I think I'm getting the name not perfectly correct, but it is a housing entity. What's that? Thank you, Jack. Thank you so much. I knew I was missing part of it. That 8 months at Kaiser shows sometimes, y'all. So I appreciate you giving me some grace at this moment. So we partner heavily across our footprint with them, and that is all they do is preservation housing across the United States. They have identified that housing is not only about production, it is heavily about preservation, and a lot of that goes to the land issue. So that's an example of where KP works with community partners on the community benefit side. Less so, though, identically with other health systems, I would say.
Okay.
In all transparency. And that may shift, but at this moment, it looks a little more community partner oriented. Does that answer?
Yeah, well,
Yeah.
It's your answer,
Okay.
so that is the answer. Yeah.
That's the best you're getting.
Steve, you want to speak to this at all? I mean, Mercy Care, do you work just in Atlanta, in the region?
Yeah, we're simply local, and actually in DeKalb and Fulton, according to our the funding that we get from, we're a federally qualified health center, so we benefit from funding that comes down from HRSA and the Health Resources and Services Administration. So we principally are focused in DeKalb and Fulton, though we'll serve someone from any county or anywhere they come from. We don't turn anyone away at the door because they're not from our service area. Yeah.
Okay. Jeff, I want to go back to Stuart's kind of framing out how Convergent works. What was your reaction? I mean, are there ideas that we can use here for ARCHI?
I definitely think so. I mean, I want to emphasize that he brought up community health workers one more time, because I do think we all should be thinking about who are those community connectors, right? I was reminded recently of violence interrupters, right? And that they've been doing such tremendous work with Grady and with others, and they are community connectors, right? Much like community health workers. One of them is one of our advisors on our advisory community practice, and he says he spends most of his time helping people think about how to get access to different services they need, right? He's not spending as much time on violence interrupting as I thought. It's really, there's tremendous needs in the community that he's trying to help with, so he's almost doing like a little bit of case management from the street. These are what our violence interrupters, our community health workers are. These community connectors, I think they're really important for us to be thinking about. And funding, right? There's not enough funding. There's not Medicaid funding right now. There's not kind of a reliable source of funding right now. And so we've got to be able to build that more. There's a little bit of that happening with peer support specialists under behavioral health. So the state has done some initial steps there that we think we can kind of continue to grow with. But there's more needed in terms of emphasizing those community connectors that can really bridge those gaps. What we're learning is, once we leave that doctor's office or that hospital room, there's really a lot more that's needed in terms of that support. The other thing I would say is around those, like you said, Bill, is aligning those payment systems. Really, we still have, we still don't necessarily have the right incentives in healthcare, right? Sometimes our incentives are around treating people when they're sick, as opposed to helping people, as Stefanie said, to actually prevent chronic conditions, to prevent illness, to be healthy. And so we still have some challenges around the wrong money in the wrong pockets to really accomplish what we want to accomplish. So some work needs to be done. Some great health economists are continuing to look at that and look at value-based care. And there's been growth in that, but there's still more needed.
Okay, thank you. Let me open it up and see if the folks have questions here. Eric? And identify, no, just, okay.
Eric Speakman. This is a great topic. I appreciate you all doing this, and I love the thought about you've got to have housing for health, but also a very wise community developer person taught me several years ago that that you need health of those people that are marginalized to be able to access the services. So I think it's a give or take. Any advice for smaller federally qualified health centers, that are really working with marginalized communities that want to address social determinants, so you're more on wellness and prevention than reaction, that especially housing. They'd say, wow, how can we do anything around housing for the people that we serve? So any advice would be great. Thank you.
Oh, who's going to draw the short straw on this one, huh? Comments?
Yeah, I'll borrow your microphone. I would say that there are so many ways that I understand the capacity challenges for smaller federally qualified health centers. Same thing that we're seeing for capacity of any of the wonderful nonprofits that collaborate with ARCHI on a daily basis. And what I would say is there is power in collaboration. How can we ask them to kind of be a part of some level of sharing what their challenges are, and then being able to think out loud together? I think there's a lot of wonderful resources, a lot of wonderful resources in the room that could help with kind of thinking about that capacity, helping think about even our resource hubs appropriate for different federally qualified health centers. I think there's some capacity building that can come through the collaboration. And I understand that that's tough, right? How do I even find time to collaborate if I have no capacity, I don't have enough staff? But what I would say is if they can make a little bit of time, my sense is that we get a really good return on investment in collaboration.
I'm sending them your way.
Yeah, and I would echo that. I mean, Mercy Care was a small federally qualified health center 40 years ago, and it was largely through the dogged determination of leadership and the building of partnerships that made it possible for us to grow.
Questions over here? Let me get the mic.
Good morning. First off, I want to say thank you so much for touching on such an important topic.
And you are?
Neve Anderson. I'm the housing resource specialist at Thrive SS. I also do a lot of consulting on the side around DEI issues, which is like what one of my questions are. They go hand in hand, I promise. So the first one is when we talk about, affordable housing, right? One of the things that I've noticed is that what's considered affordable is actually in allegiance with the market rate, right? So what I mean by that is, even though we would like to say certain housing is affordable, like when you look at either tax credit or workforce housing, if you make around $40,000, you don't qualify because you're considered to make too much. But at the same token, you can say that you can't make this much, but then charge, $1,500 or $1,600 a month for the rent. And as we know, it's extremely unrealistic and inequitable, right? So with your housing plans and with, your, hands within most of these properties, right? How do you assure that there's true equity housing, especially around low-income folks and marginalized folks, with the rent market rate constantly going up?
Yeah, so Thank you. Thanks for being here. So at Kaiser, which this was new for me because we called it DEI, as we do in most of the marketplace, but at Kaiser it is EID. And so EID is implemented into everything we do, and that includes the Housing for Health project. Stabilization is part of that process. The application process is heavily influenced by EID elements, and it does look different based on what part of the housing units, where it is in the city, et cetera. Who we're looking to attract to that particular development, it looks different, but it does heavily reflect EID and the individual, if working poor, if you will, considering credit. Credit is a huge issue for,
Absolutely.
right? You need money to get credit, and a lot of folks have never had that opportunity in their life, so that is reflected as part of the process.
Because of evictions also because of financial hardships, yeah.
Yes. I also would love to mention that today. Thank you for that opening. One of the things Kaiser will be piloting this year in Georgia on the south side is a medical legal partnership. And this is something Kaiser is doing through most of our footprint in the United States. But to your point, it correlates directly to eviction. And as we talked about earlier, it correlates to dehumidifiers because of asthma rates and mold, et cetera. And we will have a partner in the Atlanta and Georgia community working with us to represent members who are affected by exactly what you're talking about. Eviction, predatory eviction, again, mold, asbestos, all of that. It's called MLP, and it is a huge part of where housing and housing activism is going in the U.S. So that's part of, that will help us as we look at if someone was evicted that we're trying to get into one of these, our housing additions, et cetera. So I think we're covering a lot of that. I also wanted to share, I talked specifically about the 53 million, but I think what is pertinent for today is that is 819 units either preserved or produced in Atlanta, and it's the investment from KP Georgia is $13.9 million. So this is real housing, which I really want everyone to leave here understanding today. These are actual produced and stood up units.
So here's a question. She's asking an equity question. Jeff showed us a slide to show health outcomes depending on zip codes. I wonder at Mercy Care or at Kaiser, do we look at zip codes? Do we know where the greatest need is? Do we lean in there?
Absolutely. Everything we do, thank you again. Everything we do is informed by a community health needs assessment. Most all health systems in the United States, their community benefit is led by their CHNA. We do a CHNA every 3 to 5 years. This year we're doing the CHNA in collaboration with Georgia Health Policy Center. So it will reflect specific to what we refer to as our hot zones. Those are our zip codes when we look at a heat map, if you will, where the greatest need is, where the redlining is, where the lack of access to food is, where the lack of access to MARTA is, frankly, so that you can get to a health center. So all of that will align together.
So Jeff, when you're at the table with healthcare groups, is that part of the conversation? And we're looking specifically at zip codes and where the greatest need is?
Absolutely. For instance, right now, there's some work with Emory on maternal health that we've started. And the core is not coming from one of those heat map areas, but where they're seeing their maternal health needs is in areas where there's high refugee, high immigrant population. And so that's where, it's fulfilling those heat map needs. We want to make sure that we're focusing not just on, better health for all, which is important, but we really need to be, if we want to invert the burden, we've got to be thinking about those who've been most marginalized from good health.
So we've got to be smart.
Absolutely.
Right? The person beside you is asking a question too.
Yeah,
so I'm going to let her ask that before you ask your third question. Let her ask.
So Jeff, you had mentioned about organizations and collaborations as a possible way to break silos. My name is LaTanya Wilkins. I work for a nonprofit in East Point, Georgia called Thrive Support Services. Me and Neve work together. And I've been working with the houseless population for some time. Like Jeff mentioned, I work with him. Now I specifically work in the population of people living with HIV or at reason for HIV. And we all know that, housing is a huge barrier to adherence. A lot of nonprofit organizations, smaller nonprofit organizations, especially in the field of working in the HIV field, are in competition for these pots of money. So the silos exist because we are having to, one up the next organization in order to gain access to funding to continue the services that we offer. We are a non-clinical organization, so that makes us less competitive in a market. However, we are still trying to make sure that we meet that particular need of the people that we service so that they can maintain adherence and gain undetectable status or possibly prevent acquiring HIV. Some of our members are having to resort to sex work for survival. And
so I know there's a question.
So, and I guess I'm just asking, what is it that, as far as funders, we can look for them to support the need to mitigate the need for competition in these areas? Like, my organization provides supportive services. Mercy Care might provide clinical services.
It really gets to that wrong pockets thing. Everybody's got to make whatever they're measuring work, right?
Yeah, so I guess, I'm just trying to figure out how is it that we can continue to help to create some sort of equity for our members and not have to be forced to be in competition with other organizations for this same small pot of money. We know we've been fighting for them not to reduce HOPWA funding and this, that, and the other, and that's a whole nother thing with HUD. But I'm just curious to know what your take is on how to mitigate some of those constraints.
Thoughts?
I mean, what I would say is my experience is, and even recent conversations with those in the housing and HIV space, is we are still grossly underfunded. And so, I do think philanthropy has a role, and Bill, I know you've done a lot of work with philanthropy, and ARCHI has started to kind of just do some roundtable to try to get more awareness, particularly around health equity issues. But I do think advocacy is going to be even more necessary. I know that Georgia Equality is doing a lot of work around the HOPWA funding. I think we're going to have to continue to work together on advocacy and raise more awareness about this, what I feel like is grossly underfunded housing for people living with HIV.
Any other comments?
Okay.
Question?
Okay, so just
I've got about 3 more, so I'll come back to you if I've got time, okay?
Who? Maria?
Whoever's up next, yes.
Hello, I'm Maria Saporta, journalist. No one has talked about the impact of the closing of Atlanta Medical Center and South Fulton, and it seems like that is so central to this conversation. That happened, I guess, at the end of 2022. Have we seen how that fallout has impacted the community? And I'm struck in hearing y'all talk. It seems like 2 steps forward, 1 step back, or I don't know if it's 1 step forward and 2 steps back. Can y'all give me some clarity?
Some days.
I think I can put my old hat back on, Maria Grady. As my education and into the maternal health space continues, that's one of the most prevalent areas. I think where we have seen, we continue to be one of the lowest ranking in the nation as far as maternal mortality goes, and there is a specific correlation there between that AMC closing and the number of women getting the type of earlier care that they need. That's one place that we see it. We see it, it's pervasive throughout the state, but I would say that's one specific place we know it's reflected. I think in years to come, unfortunately, until we find the solution, we'll learn more about the impact. But at this moment, I think that's one of the most predominant.
And I think your question, Maria, really begs the question. If you've had to close down a hospital for whatever reason, do your investments in other places reflect, right? Are there extra investments by Wellstar or others that have to take that action? Jeff?
I can't speak for Wellstar. We are concerned that there have been some really great next steps that both Grady and Morehouse School of Medicine have done to meet needs, particularly in East Point. We are concerned, as we did a number of focus groups with Morehouse School of Medicine, to just listen to those who've been impacted by hospital closures. There's a sense of abandonment. There's a sense of, I don't have a health home. No one really cares about my health. I'm trying to manage safe streets and transportation. I'm trying to manage all these things, and now this happens. So I do think that continuing to innovate around solutions, we know that just a number of having the right beds is not the only thing, right? We've got to have really great community, kind of into the community interactions, right? That we're seeing, again, with community health workers and with these resource hubs models. But I do think that we've got to continue to think through and listen to these communities and say what is needed. Some really great collaboration that's happened in East Point. The mayor of East Point has stood up a health equity advisory board, and they've hired a community health worker in East Point. There's some pretty exciting things that we're seeing in that municipality we've not seen in others. And so they've kind of taken the ball and said, we're going to do something different about this. But I still think that we as a system have to be thinking about how do we continue to respond in a way that builds health equity, that doesn't actually make it worse, right? Oftentimes after a crisis, we throw money at something, and that is not sustainable. It is not sustained. We want sustainable change.
I also do wonder how the Grady expansion, the neighborhood health center expansions, I don't know the exact geography, but my hope would be that it will support that what was that AMC footprint as well. That will of course take several years, but that is at least progress, right, in community investment.
In the back.
Hi, I'm James Alexander with Mercy Housing, and we create affordable housing, and we also provide supportive services for the families and seniors who live in the housing. And I think some of what we're hearing is that there are community-based organizations that are providing a lot of these social services, that have built trust with communities and the people that they work with. And so they're doing a lot of that community health worker work already as a part of their scope of work. But often they're too small to have a conversation with the payer or a hospital that is fundable. And so I guess my question is, what's the best way for community organizations to present themselves to payers or to hospitals in ways that can fund that work of community health work in neighborhoods?
Good question.
Thank you. Yeah, and I'm glad to, thank you both. I'm glad to talk offline after, because it is specific to, a lot of it is specific to funding, right, and grant making. But it is the story. It is the compelling nature of the story, and it is obviously a space where there is far more need than there is resources, right? We see that in every vertical of the economy, if you will, teachers, et cetera. But it is the individual story of that nonprofit and the compelling nature of it and the metrics, the outcome. For Kaiser, it is about the outcome, what we can move. There's a history of grant making and funding all over where we were not as sophisticated and as metrics driven when we partner with communities, not just healthcare, but philanthropies and different foundations and funders throughout. And so where the marketplace is moving is towards metrics. And that's important, right? It can feel at times, especially from your position, competitive and challenging and daunting. But when you look at the reason for it, to truly move the needle for each individual and create impact, right? You can see how necessary it is. But it starts with the story, to answer your question, and how the work stands out, how the work is, I think you sat back down, Yeah, how the work is specific and moves the needle. So again, I'm glad to talk to both of you about what grant making looks like. KP, as part of our portfolio, has specific grant making done in the HIV/AIDS prevention space. And I'd be glad to put you in touch with our grant maker, who's our subject matter expert there as well. She could probably help you.
So there's a question that came in from people viewing. And James, I'm putting you on the panel. You just stay where you are, but this will come back to you too. Can your panelists speak to Stuart's comments about the need for federal, state, and local government to be a part of the collaborative? We don't have them here today, but James, I know part of your model. Where are they? Like local, state, federal government in solving this? Because just like the community benefit, government is there for the community benefit. That's why we have government. Are they at the table?
I think it's on us to make sure they're at the table. I do think we've
Is it hard to get them at the table?
In some cases, yeah. In some cases, it is, Bill. I mean, we see that the state level, and we've leaned in with wonderful groups like Georgia Watch that spend time in advocacy with our state level legislators, and to be able to, because Medicaid comes at this. These are state level decisions. Those are not necessarily federal decisions. Those are state level. So it has behooved us to spend more time thinking, even though ARCHI really focuses locally, it behooves us to think about state level policy and making sure we're thinking about, well, who are community health workers in different parts of the state that might be able to advocate locally? How are health systems in Middle and South Georgia seeing the same things as health systems are here, and how can we align with those advocacy pieces?
So I'm going to put Natalie on the panel too. So you're working between meetings every day with House ATL and have a lot of different work groups. Is government at the table with your groups?
I'm coming.
Here's a mic. So.
Yes, we have local and state government at the table, not federal, but local and state, yes, working within House ATL.
And to Jeff's point about us needing to expand Medicaid where the real money is, I mean, where's that? Where's that in the country?
I mean, that's definitely been discussed within House ATL, the need for Medicaid expansion. So, we're not the experts in how to do that advocacy and make that change happen, but it showed up in our strategic planning process, in the problem statements, and in the policy recommendations.
Okay. Question in the back, right here.
Yes, hi, good morning. I am Tanya Jones, and I'm with Atlanta Metro Properties and HomeSmart. I heard Jeff mention housing for hospital staff and helping provide affordable housing for people who work for various healthcare organizations. So I'm wondering if any of your organizations have considered an employer-assisted housing program that can be added as an additional benefit to help staff purchase first-time buyer homes. And I mention that because June is National Home Ownership Month. Yay. So, it's wonderful that you're offering opportunities for rental units, but have there been any thoughts about providing employer-assisted housing programs that can help retain staff, that can help staff be a little closer to work, those kinds of things?
I love the idea. We have not. All we did is built affordable housing right next door, which was a small thing, but I love the idea.
Well, and I understand, particularly when working with low-income house, LAHTC, the housing credits, that there's kind of like Mercy Care can't say we're going to give favor to our own workforce, right? They have to make it completely open and an open application process. I do love the employee-assisted benefit. I think that's a smart idea that we should be taking out. Thank you.
I will add, though, and I'm kind of glad Eamon is gone. I hope I'm not saying anything wrong, but our employees will get priority if they qualify. So, but nothing in terms of direct aid to them for that as a benefit.
Right over here.
Hi there. I'm Sarah Amos. I write for Decatur-ish, and to that point, what's going on in DeKalb County, right? Generally speaking, and specifically housing. Any plans for something like McCauley Station? Is there existing housing that Kaiser has invested in? All that.
Clarkston, which is one of the places where,
Yes.
yeah.
I'm glad to look into that for you. I have most of the footprint by zip code, but I don't have it specific to DeKalb in my mind. So I'm glad to follow up with you if you want to get together after. Yeah.
I do want to add that ARCHI had the honor to work with several municipalities in building well-being specific initiatives, and both Chamblee and Decatur leaned into their housing needs. And so particularly the mayor of Decatur, my understanding was pretty successful at kind of pushing back some NIMBY work that was happening in Decatur. You know more than I do. But I think there's some good examples of local municipalities where you talked about local policy, local municipalities saying, yes, we are going to stand up for housing, we're going to stand up for equitable housing, and kind of pushing back some, I get it, we all have, whether we know it or not, we all have some NIMBYism, right? Not in my backyard, but I do, I have to give credit to leadership in Decatur and Chamblee for standing up and saying we're still going to push for housing.
Good.
Okay, thank you. So this goes back to my first question, right? So, like I said, I specialize in DEI related policies as well as topics. So this one is particularly around gender diverse individuals. So as we know, most of the times that folks who are either sexual or gender diverse, they're only able to get help once they're diagnosed with HIV. And as we know, HOPWA funds are damn near depleted, right? So I guess my question is for the folks who aren't negative, who are negative, right? And the folks who do still experience discrimination, et cetera, considering the fact that trans and gender diverse individuals make 1% of the population, has there been any sort of equitable policies or strategies that you all are trying to implement when it comes to that subject matter? And if so, what are some steps that you all are taking?
I'm glad for them to answer, and just to know in the program, we're going to talk about equity next. So it's not just, yes.
What I would say is we're at the beginning of a number of conversations around that. So I would say that ARCHI has been continuing on our learning journey, and particularly, I would say there's a number of us on the ARCHI team who have really leaned into how is this showing up in our LGBTQIA population, right? Particularly when we look at premature death rates for trans individuals, and that this is something that we're going to need to do more leaning in and listening. So would invite you to help educate us and help us on the journey, if you would.
In the back. Yes, sir.
Yeah, good afternoon. Good morning. Fred Stevens, Regen Community Advisory. I've been community development work for the last 20 years. Heard a couple of comments about programs and efforts around integration between housing and health. I know Stefanie mentioned Enterprise Community Partners. A few years ago, they started a program around Health Begins with Home, which was the integration of health providers in that subject, in this area. What I hear today, and what I heard back then, and it hasn't changed much, is there a pathway to integrate this efforts around single-family housing, resources for single-family housing preservation and work? Because oftentimes what we hear is that the multifamily providers, there's efforts around building health centers around multifamily units, but many of these communities that we're referring to, oftentimes the disparity numbers are oftentimes with individuals that are in these single families homes that have had years of deferred maintenance, health issues related to indoor air quality, asbestos, and other things. Is there a pathway to provide resources for that area through community-based organizations?
Thank you. I think at this moment for KP, the greatest reflection of that is our partnership and funding of Westside Future Fund. It speaks to exactly what you're questioning, which is single family home and preservation, taxes, right? Taxes because of what we have found with the the building of Mercedes-Benz Stadium and how the West Side, the historical West Side looks so different. Support for paying those taxes as the amount for the family has gone up dramatically since there's been so much development on that side. So I think that's the most specific example from a KP viewpoint.
Thank you.
Hello, my name's Beth Brown. I'm the CEO of several public housing authorities in the metro Atlanta area. And as we redevelop our portfolios, especially if we have land or housing near hospitals or healthcare providers, what are your recommendations? I saw that your Penrose development has respite units in it, but are there any other things, if money were no object, what would you like to see in affordable housing communities to address health-related issues?
Okay,
Well, there's a softball question.
I mean,
Tell
I
her
would
what
say
you need.
I mean, all of the things you've just heard, we've got to have more housing that's dedicated for people living with HIV. We've got to have more housing. What I really appreciate is the recuperative housing. There is a real challenge when folks are needing something that's not a homeless shelter to recover in, but they still need some level of support. And so there's been a wonderful collaborative that's been been kind of exploring that. So if we could have more of that, more of that recuperative transitional housing would be really helpful. I do think also permanent supportive housing. We've not talked about that a lot today, but that is, in terms of moving the needle in terms of those who are experiencing homelessness, permanent supportive housing is what we need. Lots of, and we're grateful that we see more of that at the Mercy Care complex as well. I mean, they're really able to kind of have a lot of different pieces in this one complex to really support a lot of different areas. Excuse me.
And I would say, because we've got public housing in every county, they're independent, that one of the things, the very first things we could do is evaluate the public housing we have. Is it healthy, right? Is it causing asthma? Is there any asbestos there? Are there support services to help people know where to call to get help? So that, that's something that we could do in each of our projects.
And I would also want to add that it is obviously integral, the health of the actual housing, if you will, but what is also equally as important is the ecosystem within which the housing is placed. Is there access to healthcare? Not just healthcare, is there access to a park? We talked about a park earlier. Is it Penrose? We said that that's near a park, which is beautiful. And then also groceries, right? The basics of life. And when you look at a lot of aging housing in the US, it does not have access, which is the entire healthcare issue, right? So.
Stefanie and I talked before the forum, and one of the things she asked me is, should I bring up the Houston model? It's gotten a lot of focus, a lot of publicity, and really what they did is what Stuart talks about. They were able to get that collaborative around the table, put a fund together. Jack, just by being here, you get on a panel. I know, can you talk about what we're doing in Atlanta, and is it based on the same basis of what Houston has made great progress on?
Sure. There's a lot of similarity between what we're doing in Atlanta and what we're doing in Houston, in no small part because a lot of our strategic planning, our last two strategic plans, we've had as our consultant that helped us go through the process, Mandy Chapman, who is from Houston. Houston's on a lot of people's minds because of a recent documentary that was premiered at the Housing First Partners Forum that was held here in April, and it focuses on housing inequities across the country, but it singles out two communities, Houston being one of them. And Houston has done a great job. They've also had a couple of black eyes. They had a huge hurricane that flooded the city and knocked them back on their heels for a while, but they've shown great resilience and creativity. Every community's different. Houston, for example, doesn't have zoning, but there are similarities. They don't have healthcare expansion in Texas either. So we've learned a lot from Houston. Maybe once in a while, one of our ideas have trickled back down there that they've learned from us. But there's active, ongoing collaboration between those two communities.
So the regional commission and the Partners for Home are tables that are a collaborative table, right?
Right. And Bill, since you gave me the microphone.
Okay. Well, I'm giving you 2 more minutes, Jack.
Okay,
I'm running out of time.
I want to pick up with where you started after the little video clip with Stuart. We know what to do. We have the structures and the ideas. It's up to us to execute now. We have political leaders that are focused on this issue. As Jeff said, everybody knows about the social determinants of health. Everybody knows of the centrality and safe, secure housing in that regard. We just need to execute. It would be great if we expanded health care coverage. Our governor, who stays in office for another few years, has said 2 or 3 times openly in the last 2 or 3 weeks, it's not on his watch. So I think unless he changes his mind, we need to quit hoping for that holy grail in the short term and get about the business of solving these problems with the resources we can get access to.
Point well taken. We have had several questions today about equity, and I think when we talk about affordable housing, it really comes back to that. So I have matters of affordable housing and access to health care and other needed services that disproportionately impact people of color and low-income families. I recently talked to Robyn Bussey, who leads the Just Health initiative at Partnership for Southern Equity. And I want to share some of her comments. She couldn't be here today, but I thought it was important to hear from her. So could we roll that?
Hi, Robyn. Welcome to the Regional Housing Forum. It's so good of you to join us. I'm sorry you can't be here in person, but appreciate you taking the time to do this recording. Maybe we'll just start. I think most of the audience knows, but just tell us a little bit about the Partnership for Southern Equity.
Absolutely. It's Partnership for Southern Equity. We are a racial equity nonprofit based here in Atlanta, and we advance equity and shared prosperity for all throughout Metro Atlanta, Georgia, and the American South. And we do that through an equity ecosystem that encompasses different areas where folks' lives intersect. We have energy, equitable growth and development, economic opportunity, and health equity, which is my portfolio that I lead, which is Just Health. And we work to advance equity through training, technical assistance, working with organizations to operationalize health equity, to understand what it is, particularly through the lens that we see is the primary driver of health inequity, which is structural racism. And we also work with communities to build their capacity for advocacy for health equity. So we do that all over the state, all over, hopefully, the American South and eventually the global South.
I figured you guys were already working across the country, so
absolutely.
And I know you cover the waterfront, but today we're really focused on health. And doesn't it always come back to health?
It always in my life, yes.
It really does. So maybe just say a little bit. What's at stake here? Why is health kind of the indicator? I mean, we've got plenty of data, that says it's a primary indicator, but speak to why it's important.
And I guess in my world, again, it all comes back to health. Health for me, and I think for everyone, intersects everything. It underlies every part of our lives. So when we're talking about our education, we're talking about where we live in particular. We're talking about our, how we eat, what we eat, the air we breathe, all of that comes down to our health and it impacts our health. So when we're talking about housing in particular, it's really hard to think about your health, to be able to advance your health if you don't have some place to live, to come to every day, to be able to be safe, to be able to know that your family is safe, to be able to recuperate, to really feel like you have a home. That takes a lot off of your plate every day if you know that you have some place to be and to be safe and to allow you to be healthy. That covers your mental health, your physical health. It allows you to be able to earn an income, hopefully a livable wage. All those things, again, allow you to be healthy, from the, basic opportunity to get health insurance. So again, allowing you to access the healthcare system to be able to maintain your health, hopefully prevent disease. All of those things, believe it or not, tie into being able to have a nice, safe, affordable place to live. And I think those things are very important. When we say housing, it's very important to say safe and affordable when we talk about housing as well.
Absolutely. And you may know my background in food security at the food bank. Housing Forum came out of the food bank because anybody we were feeding was paying too much rent or didn't have a place to live. So, all these things go together. I know you've been active in East Point and you've had some experience in this. So I think the folks here would like to hear about that briefly.
Yes, so in addition to being a longtime resident of East Point, I was appointed a couple of years ago by the mayor of East Point to be a commissioner on the East Point Housing Authority Board of Commissioners, and have served proudly in that position and learned a lot about public housing. And one of our initiatives I'm really proud of, very recently, we opened what's called ARCHI Tower. It's a multifamily housing complex in East Point. It's the tallest building in East Point, so you can't miss it.
Well, let me just congratulate you there.
Thank you very much. It was truly a labor of love, work that started way before I joined, but so proud to be a part of that. And what's really exciting to me, of course, being in the health equity space that I occupy, was that United Healthcare was actually an investor in this development. So for me, having, United Healthcare, a major health payer, realize and recognize the importance of being a part of this, being able to create affordable, safe, quality housing for the residents of East Point, a community that is mostly Black folks and folks of color, a community that does not have a really high median income. So just, for them to realize and recognize the importance of being in housing and how housing, again, health intersect is really important. And
is there anybody else at the table? I mean, Stuart Butler talked about the need for collaboration, getting all the partners together.
Absolutely. So the Vecino Group, of course, was a developer in that work as well. And in addition to the Housing Authority, we're having conversations with folks like the Morehouse School of Medicine, who've committed to work in advanced health equity in East Point. We're having some conversations with Grady Healthcare as well. All of these folks are committed to really working together to fill that kind of healthcare desert that we have in East Point that's resulted from the hospital that we had at one time leaving, and recognizing that folks in East Point and the surrounding areas not having that readily accessible access to healthcare and healthcare services.
Well, I guess the last question, and this is really the core of what we've talked about today, is East Point a model of a kind of collaboration? I know it's not done. I know it's challenging. Everybody's trying to figure out their role, but do you think it's a place that we could look to in the future?
Totally biased, but I like to think so. I absolutely would like to think so. Indeed, because we're having these conversations again with our housing authority, with healthcare partners, but we're also having it, with folks in education, with folks in transportation, with different partners, all recognizing that, while we may come from different sectors, ultimately we're working to improve the health and well-being of folks in East Point. And, once we do that, that's going to benefit us all. And of course, we'd like to see that, ripple out beyond East Point and of course, throughout the metro Atlanta area. So yes, I like to think East Point is a great example.
All right. So we're going to point people in your direction. You've almost done my summary of the Housing Forum for me, that it really is connecting all these issues, getting collaborative partners at the table, having good leadership like you provide. And we certainly thank Partnership for Southern Equity for holding that up. Thank you so much, Robyn.
Thank you. I appreciate it.
Jeff, Steve, Stefanie. And let me just do some summary statements. I think one of the goals of the Regional Housing Forum is to connect the dots, to figure out our mutual responsibility to provide safe, affordable housing for everyone. Our underlying belief is it's everyone's responsibility. We all have our individual responsibility, but it's everyone's responsibility to provide safe, affordable housing. We have in the past, and as we look to the future, we need to address issues of design, of the materials that we use to build, of the fees that sometimes add 20 to 30% to the cost of housing. We need to look at code enforcement. We need to look at the role of the public sector, at the relationship between housing and educational outcomes, the environment, transportation choices, and equity, the role of philanthropy, local and regional state government, of the university community, and certainly planning organizations like ARCHI or even House ATL. We need to look at the issue of investors coming in, investing $1 billion and taking away that opportunity. There's nothing wrong with investing. That's how capitalism works. And if they're good players, it can provide affordable housing for folks. But it also takes away the opportunity for people to invest and build their own equity. And of course, there's the issue of NIMBY, our fear of others being in our neighborhood. And that's always been there. But as we talk about, and ARC tells us, we're going to have another 2+ million people moving to this city. We're going to have greater density. We're going to have to be more creative in how we build, where we build, and how we interface with each other. So today we've looked at the connection between health and housing, but as you know, we have focused on related issues in the past. The underlying message is to make progress, we must learn to trust each other, to clarify roles, and to collaborate. We must address the wrong pocket issue and know that the best measurements of progress is, do people have a safer, affordable option for housing? I'm struck by the comment about Hattie Dorsey, that she persisted against racism, sexism. She persisted in an area that took great courage to speak truth to power. And what I hope is that we will be known in this generation, and that each of you as leaders in the community will be known as people who persisted, who did their part to do what we can with what we have and the time given to us, to use the social capital and influence that we have, even though we might feel like it's a small thing. All of us can do something. I want to thank St. Luke's Church as such gracious hosts for us, the ARC and ANDP, which helps support this effort. We're really a volunteer effort. That there's a planning committee, and we meet all through the months until our next meeting puts that together. I want to thank George Bergen. George is the guy behind the screen here who gets us organized. George, no, you come on out here. George never likes this part, but we're in a moment, folks. I've been working here. I started in this room in 1975, running the first community kitchen. And you might say, how do you stay in the work, Bill? You didn't solve affordable housing. There's still hunger. What we have to do is be faithful to our call to make things better. So most importantly, I want to thank all of you for showing up in the work that you do every day. God bless.